So, Tom, we're trying in this segment to highlight the distinction between the traditional biopharmacologic approach to understanding chronic pain and the biobehavioral approach. Let's start by a discussion of the first. Can you define for us a little bit what we mean when we talk about biopharmacologic approach?
Yeah, Jeff, this is a great question. I think this really is core to what this course is trying to help physicians move through. The biopharmacologic approach is the traditional approach that's taught in medical school, that I learned, that every physician learned, and fundamentally assumes that most disorders, including pain, have a molecular basis that will be fundamentally amenable to treatment with some kind of a drug. And that drug will be able to change the way in which, be it the lung or kidney, or in this case the nervous system, functions to eliminate a nefarious signal, for example. Things like other approaches like occupational therapy, physical therapy are viewed as useful, but they're viewed as an adjunct to the primary goal, which is to understand the physiology and diagnose specifically the mechanism and use a drug which is going to interfere with that mechanism.
Interfere with that nociceptive input to the brain.
Exactly. Yeah. And I think the primary focus is, as you point out, on the either nociceptive input or perhaps nociceptive processing of the brain, in contrast to how the brain as a whole is managing the issue.
So that's a nice lead in then to how do we understand the biobehavioral approach? How does that differ from what the typical physician would learn in medical school on the understanding or conceptualization they bring to pain?
So in contrast, the biobehavioral approach makes the assumptions that pharmacology can be helpful, but the fundamental approach to a diseased brain, which is what chronic pain is a learning process. It's helping the patient move through a series of stages so that they can unlearn some of the negative learned patterns that have happened over time. And that everything else is really secondary to that. So that the tools the physician would employ in this particular case are primarily helping the patient navigate their life, be it through exercise, physical therapy, changing life habits, seeing a psychologist to get some understanding. And while the drugs are, of course, useful, they play a secondary role rather than a primary role.
You're describing this or characterizing it as quite a collaborative process between physician on the one hand and patient on the other. It sounds as though this is a kind of a coaching process, if you will.
Right. So, and I think you're raising really just the right point right now, which is that the physician's role, even the physician's identity, changes in the room. So the biobehavioral approach isn't something like, okay, at the end of the visit, let me prescribe some physical therapy and some occupational therapy and maybe even give you a referral to a psychologist. That is not the biobehavioral approach. That's part of it, but it's not it. The biobehavioral approach begins when you shake hands with the patients, and your role has changed fundamentally from a diagnostician, a decision maker, somebody who's going to recommend A, B, or C to the patient based on your expertise. Beyond that, you still play that role, but now you've become a coach, a partner, and you're going to help the patient navigate through this very difficult process. In a way, you're no longer pretending that pain is a simple A, B kind of problem, and if I get an X-ray or an MRI and I figure out that the lumbar disc is out and I fix that, then the pain's going to go away. You're actually taking on the entire complexities of pain we just talked about with suffering, and you're embracing with the patients that you're going to have to move through this together, and this is going to take time.
So, so this takes on a different flavor in practical terms of how you might use your time with a patient in the office.
Absolutely.
You're really addressing a broader conceptualization, really introducing the notion of a more comprehensive understanding of pain to the patient and walking him or her through each of the elements that may be contributing to their overall chronic pain experience.
That's absolutely right. And in general, it takes a little bit more time to initially lay the foundation because, of course, you don't abandon the diagnostic approaches. You still need to do that work to make sure that you haven't missed some uncovered process.
Yeah.
But you also need to lay the foundation for the idea that probably there isn't going to be anything, particularly if they've seen, as a typical chronic pain patient, 4 or 5 physicians. They haven't, unlikely they all missed some critical piece. But you're going to help them move through territory they have not moved through before by asking questions about their suffering, about their lives, and through the questions beginning the coaching process. Now, that said, it may take a little more time to lay the foundation initially, but later on in the follow-ups, you're going to be much quicker because with the foundation having been laid with the idea that they're moving through something, now the follow-ups are focused much less on how much pain are you having, where is it, what are the mechanisms, and you're not thinking along those lines. You're thinking along more of the lines of how is your function, how are you progressing, what areas are you struggling with in your life. And now the visit can be much more circumscribed, focusing on the important things that are actually going to help the patient make progress.
You know, that's such an important point because we hear from docs that their time with patients is limited.
Right.
And they worry that taking new approaches will automatically bring with it longer visit times. And in an era in which visit times are often critical, the fear is that this will really add to the amount of time they have to spend with patients. In contrast, you're really saying that as physicians get more adept at this kind of more coaching style of interacting in later visits,
Right.
at least, that this actually is a time saver.
Right.
It improves the efficiency of their visits with their patient.
Absolutely, and as you know, in the 4PCP program we published years ago, physicians estimated they dropped their time from about 19 minutes on average to about 11 minutes for a follow-up with chronic pain patients. And some of the physicians felt that chronic pain had become a little bit like diabetes or hypertension, where they really understood the steps they had to take in the biobehavioral framework and knew before they walked into the room with the patients, if the patient is having this or that problem, I will know exactly how to address it, in contrast to sort of the heart sink approach of what am I going to do now?
Mm-hmm. So what elements of this have we yet to address?
Jeff, I'm going to push the conversation back to you a little bit. How would you help the patients navigate this shift? They're coming to the physician's office really having only heard the biopharmacologic approach all their lives to anything, be it chronic pain, be it anything else. And if you're the first physician to begin to help them embrace the biobehavioral model, what kinds of questions or points might you raise initially, being sure that they're not hearing something like, really, this is in your head?
So in a biopharmacologic approach, the emphasis has historically been more on symptoms, on understanding mechanisms that may be contributing to nociceptive input, and is a less sophisticated way of understanding chronic pain from a more kind of comprehensive perspective. In contrast, a biobehavioral approach truly allows the physician to adopt a teaching role where they are teaching them about the greater complexities of chronic pain, the consequences of chronic pain, bringing in more of the patient's experience, the suffering aspects of pain. And it gives, I think it lends a framework for validating that suffering, for being able to extract the patient's experience in its totality. And it also allows the physician to begin to detail a bit about patients' readiness for change. Where are they in their belief system about their pain? And are they at a point where they are ready to embrace a broader conceptualization that might also then bring with it some opportunities for behavior change?
It sounds like this is pretty complex in terms of your approach to the patient. Is it something one can learn overnight? What kind of, how might one begin to embrace such a strategy?
Yeah, it's interesting because this represents, I think, for most providers, a fairly radical change in the way they're perceiving pain and in the ways they're then teaching patients about pain. It's
Right.
a true paradigm shift. And like any conceptual framework, the biophysiologic approach has taken some years of training and years of experience, residency, fellowships, so forth, that have emphasized this particular conceptual framework. Similarly, I think learning the intricacies of this new way of looking at chronic pain also takes time. For example, if in the training of medical psychologists, this might be a 6-year process of orienting to this broader, I think, more comprehensive and more accurate framework for understanding chronic pain experience that patients bring to us.
Yeah. Yeah, I guess my own perception of it is almost like learning a new language. And you don't learn a new language quickly. It takes time. You have to practice it over and over again, which is, I think, why we've brought this sort of practicing multiple scenarios kind of approach to this training.
Yeah, I think it does. I think, like new learning, we start with repetition and truly internalizing this model of understanding before we can begin to bring our own unique style and fit this to our own own pre-existing kind of ways of understanding patient experience.
Okay.
So when we think about this, just pragmatically, how might this look in an initial visit that a patient has with a physician?
That's a great question. So let's sort of hone back down into a couple of trees here, which is just, how do you implement this? Well, I think the first thing is, because you're going to be bringing in such new concepts to the patient, you have to make sure that they understand that you believe them. The patient who has seen multiple physicians has perhaps no one has told them that this is problems in their head, but they fear that to the uttermost. So I think it's really important that the very first thing you do in your visit is you validate their complaints, that you're hearing them, that you believe this is a real problem to them, that it has in fact been as devastating as they say it has been, and that there's no question or issue that you think that they have a primary psychological problem. In fact, the literature suggests that that is not at all the case, that those patients who get depressed after they have the chronic pain issue, not before. So that's very, very important to establish that baseline and to take whatever time it takes to make sure the patient truly believes that you believe them. So that would be the first thing. And I think the second thing would be to then begin the process that you laid out to distinguish between nociception and suffering, bring to the floor the idea that there are a couple of pieces to this. This is more complex. Perhaps this is the reason that for whatever number of years they've been seeing doctors, they have not had success. And you're laying a foundation for a novel approach which is more likely to succeed.
Excellent. I hope we'll move on then to a demonstration of the way that that might play out in practice.
Right. So our scenarios are actually like practicing a new language. That's practicing some of those ways of conveying this critical information to the patient.
Excellent.
What we've learned today is that the biopharmacologic and biobehavioral models differ fundamentally in their approach to the patient who has chronic pain. That the biopharmacologic model is the one taught in medical school that makes the assumption that most disorders are responsive to a pharmacologic agent, with other approaches being helpful and adjunctive, whereas the biobehavioral model makes the assumption in chronic pain that the most powerful tool you have is the brain's ability to learn new ways of coping, to unlearn old ways of that have been unhelpful, and that the biobehavioral model then assumes that the pharmacologic approaches are adjunctive to the primary goal of helping the patient navigate through this journey. It's important to understand that the role of the physician is entirely different in these two approaches. The role of the physician traditionally is as a diagnostician, decision maker, recommender, and the patient plays a primarily passive role of saying yay or nay to what the physician recommends. In the biobehavioral model, the physician moves beyond that to become a coach, a partner in the journey the patient is going to take, and the patient then becomes a very active participant in the process. Of course, that's helpful in its own right because learned passivity is one of the fundamental issues about chronic pain that makes chronic pain so difficult. And so already in the biobehavioral model, you're helping the patient to unlearn the passivity and take on a more active role in their own treatment. From a practical perspective, in the initial visit, you want to validate the patient's complaint, make sure they don't get the message that this is in their head, because then you will have lost them immediately and you can't move on, and begin to point out the differences between the nociceptive portion of pain, the suffering portion of pain, and that perhaps the suffering portion of pain, which may be more important, has never been fully addressed by any of the previous practitioners.